A very good morning, everyone. We are on 6th of June, 2026, and we are live for yet another session. We are talking about kidney diseases and diabetes, addressing the global epidemic. Today we have a very well-known speaker and a doctor, Professor Dr. Manisha Sahay. She's a distinguished nephrologist and a transplant physician, currently serving as a professor and dean for Department of Nephrology and Kidney Transplantation, Osmania General Hospital and Osmania Medical College in Hyderabad. She's a president of Women in Nephrology and has made outstanding contributions to nephrology through clinical practices, research, education, and leadership. Her achievements include over 290 scientific publications, over 5,000 guest lectures for national and international conferences, over 13 gold medals, and several prestigious academic awards. Former Vice President of Indian Society of Nephrology, Associate Editor, Indian Journal of Nephrology. Her held several leadership positions with International Society of Nephrology, including the chair of South Asia Region Board of CMA Committee. Instrumental in establishing the Advanced Renal Care Service, including CAPD, CRRT, and Disease Donor Transplant Program in the government sector. Ma'am, we are over here for insightful session. Over to you. Thank you so much.
So thank you all. And it's my pleasure and honor to be here. So today I'll be focusing on one of the very relevant topics, which troubles everyone. I mean, physicians or practitioners, anybody for that matter. So is my screen visible? Can I go ahead? Yeah, is my screen visible?
Yes, it is.
Yeah, okay, fine. So I'll share again, just a sec. Yeah, so thank you for inviting me here. So today the topic is kidney disease and diabetes, addressing the global epidemic. So why it's important, why this topic is important for that matter, because now CKD is one of the diseases which has a huge prevalence, not only in India, but across the globe. And 10 to 13% of global population has CKD, which is a huge number. So it's important because it's huge. You can see in this slide, the prevalence of CKD. So roughly, as I said, between 10 to 30% across different countries in the world. The second important thing is CKD increases the risk of cardiovascular deaths. And you can see in the figure, the increase is phenomenal, especially if you go for dialysis, the risk increases manyfold. And most of these deaths are cardiovascular in origin. So that's point number 2, why we need to think about CKD. The third important thing is treatment is available. We all know dialysis and transplants are available, but it's expensive. The annual cost of maintenance dialysis in India is $5,000 US. In US, you can see it's $130,000 US in Netherlands and other parts of the world. So though in India it's less, $5,000 US relatively, but still it's a huge economic burden. And in developed world, it's even more. The first year cost of kidney transplant in India is again roughly around $12,000 to $20,000 US. Whereas in US, again, it's, you can see $120,000 US. So again, the transplants work out cheaper in India. However, again, comparing with the Indian economy, that itself is a huge burden. So that's the same story in most of the LMICs across the globe. The other important point is, I told you that it's expensive. Now, the kidney replacement therapy, that is dialysis and transplant, is required by 0.5% of population, but consumes almost 2 to 3% of the healthcare expenditure in high-income countries and up to 5 to 7% in some healthcare systems. So what does that mean? that the country as a whole has to spend a big percentage of its GDP taking care of dialysis patients. Because once you have started the patients on dialysis, which is a life-saving therapy, obviously you cannot stop it. So for managing dialysis patients, you have to invest a huge percentage of your GDP. So it leads to out-of-pocket expenditure for the family. And even in countries where the dialysis is supported by the country, by the government, it's a huge burden for the government. So that's point number 3. Huge burden, high cardiovascular and all-cause morbidity and mortality. The treatment is also expensive. The other problem is treatment is not accessible to all. So we know that the treatment is either in the form of dialysis or transplant. Dialysis can be peritoneal dialysis or hemodialysis. They are life-saving therapies, but only about 1/3 to 1/2 of world's population who needs these renal replacement therapies get it. They don't have access. They simply die because either dialysis is not available or transplant is not available or the numbers are less. And in low middle income countries, this problem is compounded, like in India. So 90% of patients in high income countries who need renal replacement therapy get it. But if you look at India or many parts of South Asia and Africa, less than 20% get hemodialysis or transplant. So treatment is not accessible universally. The 5 important point is the leading cause of chronic kidney disease in the globe, across the globe, is still diabetic kidney disease. And you can see the number of diabetes people across the world is growing like leaps and bounds. So 463 million in 2019, projected to 762 million adults in 2045. So there is a proportional increase in diabetic kidney disease because of the increasing number of diabetic patients. And the low middle income countries, where 78% of the CKD populations reside, will bear the heaviest burden. So that's why today's topic is really important. We have to open our eyes and look at it. We have an epidemic now of diabetes and diabetic CKD. And you can see the numbers, the sheer numbers. So if we presume that around 30 to 40% of all diabetics will develop diabetic kidney disease, then look at the numbers in the different countries. Asia will have the huge numbers because of the magnanimity of its population, the number of people with diabetes. So can you imagine 140 million patients with diabetic kidney disease? That's a huge, huge number. So these are the 5 important points why we need to worry and look at the diabetic kidney disease. And the most important point why this topic is relevant more so now, because till now we used to think there was no prevention. Once a diabetic kidney disease, you are going to end up in kidney failure and need dialysis or transplant. But now, this day and age, 2026, prevention is imminently possible. So we should change our mindset that kidney failure should be an outcome we fight, not a fate we accept. And kidney failure is no longer inevitable. It depends on you. It's negotiable. So you can think of preventing dialysis or transplant. So we have understood that why it's important to look at these patients with diabetes and kidney problems, because we can treat it. But what are the challenges and how do we meet them? So most important thing is we should pick up these patients of diabetic kidney disease early. And once we pick them up, we should follow the treatment guidelines, which often does not happen, be it high income country or low middle income country. So let us first talk about how do we diagnose these patients early. And I start with a typical example in our country, which also resonates with other low middle income countries as well. So imagine yourself sitting in the clinic in a peripheral hospital. Type 2 diabetic visits you for the first time. So Mr. S, 47 years old, software professional, type 2 diabetes of 5 years, hypertension 3 years, does not have any cardiac disease as so far, has a non-proliferative diabetic retinopathy, doesn't have any kidney symptoms, looks fine, urine output is good, and there is no history of any swelling. He's a smoker, non-ethanolic, consumes a mixed diet, and he is obese. BMI is 28. Blood pressure is 144/94, about which he is happy. He says it's well controlled. HbA1c is 8.3. So, and this is the prescription most often seen: metformin 1 gram BD for his diabetes, telmisartan 40 milligram OD for his blood pressure, and glimepiride 2 milligram BD for his diabetes. So this is a common prescription, and this is a prescription taken from a real life case sitting in the peripheral hospital. So is that enough? I mean, in 2026, is that the prescription? Is that how should we treat these people? What should you do ideally? Remember, this patient does not have any kidney symptoms, no swelling, no urine output. But keep in mind, the early stages of kidney failure may be completely asymptomatic. Kidney failure goes through 5 stages. And most of the times we are picking up kidney failure in stage 3, 4, or 5 in the nephrologist clinic, which should not be the case. We should pick up the early stages, the asymptomatic stages, that is stage 1 and 2. And how do we pick up these early stages? For instance, our index case, no symptoms. Should we still test for kidney problems? Let us see. Remember, you have to screen for kidney disease. Do not wait for the symptoms to appear. And what are the tools you use for screening? Simple 2 tools: urine albumin and creatinine in the blood, serum creatinine. And with the serum creatinine, look at the eGFR. So eGFR looks complicated, but again, you don't have to do anything. Just everybody, all of us, should download that app, the calculator, GFR calculator, on our smartphones, and can use that. You just have to fill the age and sex of the patient and the creatinine. So it's very, very important. We all know about it. But unfortunately, the sorry state of affairs is that we get many patients sitting in our OPD who have been diabetic patients for 10 years, not a single report of either albumin or GFR. So this should change. All prescriptions, whether given by a primary care physician or a specialist, should be the same. You should mention GFR on the prescription. You should mention the albumin on the prescription. So this screening is important. Also remember that you have to do both albumin as well as GFR, because some patients, around 40% of diabetic patients, may have no albuminuria, but only the GFR may be low. So therefore, combined assessment of albumin and eGFR is essential, and the test costs around 100, 150 rupees in government sector. Even in the primary care centers in the villages, rural areas, you can get these done. Their albumin may not be available, but you can do a urine dipstick and you can do a creatinine. Those facilities are available and should be utilized. They are not high-end facilities available in government sector. Because if you are not looking for DKD, you are definitely missing it, as it was missed in the index case. Remember, even a normal creatinine can hide abnormal kidneys. Always check the GFR. Don't only rely on the creatinine. And remember that albuminuria is called the HbA1c of the kidney. So you have to check the albuminuria as well. So as I said, if albumin is not available, check urine protein. That's available everywhere. You can do it with a dipstick, right? So this is how you screen the patients. Unfortunately, screening is not universal. Even in the best of centers across the world, look at the percentage of diabetic screened for CKD. Even in North America, it's 65 to 85%. And the percentage further comes down in countries, for example, Africa, it's just 10 to 40%. So this is a missed opportunity where we are missing early detection of CKD and early prevention. So what is happening is CKD is diagnosed in the last stage. This is because of lack of awareness. Some people complain of lack of screening tools in peripheral areas, and this should be ensured. Most of the primary care centers now are having the tools. Albumin, though, is not available. And the problem is, other thing is, nobody asks and nobody audits, and there is no penalty for not screening. So these are the problems which need to be rectified across the globe, whether you are sitting in HIC or any country in Asia. Screening should be universal, and 2 low-cost tools should be used for screening. Remember, diabetic kidney care should start in the family physician's clinic and not in the dialysis unit or after the patient has a heart event in cardiac ICU. So it should start in the primary care physician clinic in the remotest part of any country. So for our patient, Mr. S, urine albumin was done, which was 640 milligram per day. He was asymptomatic. Normally, we know should be less than 30 milligram per day. Serum creatinine came out to be 1.9 milligram per day, though he did per DL, though he did not have any symptoms, and eGFR was 43 ml per minute per 1.73 meters square. So this is markedly abnormal. So once having found these reports, try to grade the severity. So do a CKD staging, and this is called CKD heat map. It is again available online. Just click CKD heat map and try to find out where your patient lies. The G1, G2 depends on the GFR, and A1, A2, A3 are based on the albumin categories. So unfortunately for Mr. S, where was he? He was in stage 3B, A3 class. So already he was in the red zone already, though he looked completely asymptomatic. Therefore, screening is very, very important. So the first step we have completed, that diagnose CKD in a diabetic early, screening, and find out where that person is. The second important thing, what you need to do across all countries, across all populations, rural, urban, anywhere, across all specialities, be it a cardiologist or a nephrologist or a physician or a primary care, whosoever, follow the treatment guidelines, the 10 commandments. To simplify it and to remember, think whether you are following all these 10 commandments. And what are these 10 commandments? The first point on your prescription should not be metformin as it was written there in that prescription. It should be diet. Weight control is very important, especially in obese patients. And there are many formulae available for ideal body weight. And in a busy clinic, we may not do it. But remember, height in centimeters minus 100, at least use that. So if this person's height was 169 centimeters, the ideal weight should be minus 100, that is 69 kilogram. You check this, it's fine. It's better than not doing anything at all. And in Indian patients, also look for central obesity. So we do a waist circumference as well in Indian patients. So any patient anywhere in the world, first point, concentrate on the diet, tell him or her about the ideal body weight. Tell the target that you are 95, sir, you need to get down to 69. Fine. So now the diet should be, we all know again, that rich in carbs, but carbs should be whole grains, fiber, brown rice, millets, etc. Avoid refined carbs like maida, white rice. Those things should be avoided or limited. Protein, 0.8 gram per kg per day. So here I would like to emphasize that generally we take around 1 gram per kg per day. That's fine. Now, CKD, you need to restrict a little, but that doesn't mean that the patient should stop everything. The common mistake found is they stop even the vegetable protein, which is not required. Vegetable proteins, pulses, etc. can continue. No restriction for vegetarian patients. Avoid red meat and avoid processed food. That should be the message. Vegetables, everything can be taken. Fruits can also be taken. Even till the last stage of CKD, just take care of the potassium. If potassium is normal, fruits can be taken. And you can always go for low potassium fruits. Avoid maybe banana, coconut water. Avoid juices and avoid sweetened beverages. So that's most important. And this is what finally is a healthy diet, even in a non-CKD patient. So try to stick to that. In your plate, we commonly explain to the patient, if you have a round plate, half plate should be salad, vegetables, fruits, colorful half plate. 1/4 plate should be carbohydrates and 1/4 plate should be proteins. And this is same for CKD patients. So don't make them feel that the diet is going to be severely restricted. You have to make healthy choices, not no choice. So that's important. Because controlling obesity is very, very important. This is one of the main risk factors why we are having increasing diabetes, and obesity independently is a risk factor for progression. And you can see that slowly the prevalence of obesity is increasing across the globe. So that's why diet is important, controlling calories is important, and appropriate diet is important. Then remember the second thing about diet, salt is the cheapest nephrotoxin available in market. So this has to be told, and 1 flat teaspoon, not tablespoon of salt, 1 flat teaspoon, not a heap teaspoon. And people try all sorts of remedies. They take rock salt, Himalayan salt, pink salt, everything is sodium. So remember that. And also take a minute to tell the patient, avoid hidden salt. For example, people take salads, they take a lot of salad dressing, which also is salt. Avoid soya sauce, avoid pickles, pepper, especially in India. Use lemon instead of salt. Read food labels. Salt-free spice. For example, black pepper can be used to maintain the taste. So these things are important. The second point on your prescription should be lifestyle. We all know about it, but please write it down. Quit tobacco, physical activity 150 minutes a week. Whatever form of physical activity is fine. Incorporate some sort of resistance training for 2 days a week. It's important. Whatever they want to do, swim, walk, dance, anything. Need not go to expensive gyms, but make it as regular as your habit of prayers. We every day do that. We every day brush our teeth. Every day walking should be part of a daily routine. Alcohol, again, restricted. to less than 1 standard drink per day in women and less than 2 in men, but try to avoid it altogether if that is feasible. Then third point on your prescription should be management of blood pressure. The target should be less than 120 as by the guideline, but many patients may not tolerate it. So individualize, at least try for 130/80. And in case the patient is able to tolerate 120, go for it. Systolic 120, go for it. What are the drugs you should use? We all know that RAS blockers are the drugs which are the drugs of first choice in diabetic patients with CKD. Use the highest tolerated dose. So many of us are scared of the high potassium levels, fear of hyperkalemia, and we give baby doses which are not nephroprotective. So tell me, Satan, this patient was on 40 mg. That's right, but go up to 80 mg. That's the maximum recommended dose if the patient is able to tolerate it. Monitor creatinine, potassium. If the patient develops hyperkalemia, try to manage hyperkalemia by diet, by giving diuretics, bicarbonate, and potassium binders. So that's important. Don't think that managing hyperkalemia, the first step is to stop the RAS blockers. Try to continue the guideline-directed therapy, that is RAS blockers, unless the hyperkalemia is unmanageable or there is symptomatic hypotension. So that's an important message. Now, for our patient, telmisartan dose was increased, but still the blood pressure was not at goal. So calcium channel blockers and thiazide diuretics were added. So many of the patients may need a triple therapy. If 3 drugs are not sufficient, you can add a mineralocorticoid receptor antagonist. Spironolactone is a good drug, often underused because of fear of hyperkalemia. But if there's no problem with the hyperkalemia, this is a good drug to add. Other drugs come later, centrally acting alpha blockers, minoxidil or hydralazine. So this is the order you should use the drugs in. Our patient was well controlled with the triple drug therapy. So now he is doing fine, better as far as the blood pressure is controlled. So that's the third point on his prescription. Telmisartan 80 mg plus amlodipine and chlorthalidone. What about glycemic control? So this patient had an HbA1c of 8.3. We target 6.5 to 8. Younger patients who can manage hypoglycemia, who have a long lifespan, no comorbidities, target 6.5. Little bit older patients, frail patients, up to 8 also is okay. And remember, strict drug control if the patient is young, has a long lifespan, and less hypoglycemia risk. HbA1c sometimes may not be accurate, so CGMs can also be used. And what drug? Again, metformin still remains in the fray. If the GFR is more than 45, you can use full dose metformin. Between 30 to 45, the dose of metformin should be made half. In our patient, he was on full dose metformin, 1 gram BD, but should be reduced to half, 500 milligram BD, because the GFR was less than 45. Less than 30, we do not give metformin. Now, what other drugs? Our patient was on glimepiride. Is that the correct option? No. Though it's an anti-diabetic drug, remember, now the concept is holistic therapy, organ protection. So the drugs are used not only targeting glycemia, but the heart and the kidney, organ protection in CKD, also the liver. So here we are talking about kidney protection. And do we have any drugs for nephroprotection? Remember, yes, we have. We have SGLT2 inhibitors now. They target the metabolism, kidney, as well as the heart. We have this concept of holistic management of CKM syndrome. CKM means cardiovascular, kidney, and metabolic syndrome. And now we are adding L also, that is liver. So think of drugs which target the entire organs, not only the sugar alone. So SGLT2 stand number 1 there. So treat patients with type 2 diabetes, CKD with GFR more than or equal to 20 with SGLT2. So generally less than 20 GFR, they are not started. Those studies are coming up as of now, but more than 20 in a diabetic CKD, it is important to make SGLT2 a part of your prescription because they have benefits beyond glycemic control. Wonderful drugs, decrease weight, decrease blood pressure, cardioprotective, reduce hyperfiltration. They are smart diuretics, cause sodium loss as well, decrease albuminuria, decrease renal work, and they are anti-inflammatory. So excellent drugs and should be a part of prescription. This sentence is very impactful that if you use SGLT2 inhibitors on time, they delay dialysis and transplant. For example, if you start them at a GFR of 85, you have 26 years of dialysis-free life. That's a projection. And even if you start it around 20, you still delay dialysis for 2 years. So remember, dialysis is a very troublesome thing for the patient. So try to delay it as far as possible. and continue to use SGLT2 even after starting. If the GFR falls below 20, you need not stop it. So start with a GFR 20 and above, but having started it, if there is a dip in GFR, continue it till the patient goes for dialysis. Because this GFR dip is not an indication to stop therapy. Only avoid SGLT2 when the patient is sick or hospitalized, or if the patient is having type 1 diabetes. And we have sufficient trial evidence. These are all primary renal outcome trials. The Credence trial, we were a part of this landmark trial, and the DAPA-CKD and EMPA-Kidney. All of them have shown the effectiveness of these drugs, 30 to 40% of whopping renal risk reduction. Before these drugs, we never had anything except the RAS blockers. So you have this tool in your hand. You should use it. They have revolutionized the management of diabetic CKD. For decades, the standard of care was static with the RAS, but now it's abruptly changed. So we call it the SGLT2I revolution. So this patient was started on dapagliflozin 10 mg. So HbA1c now 7.8, UACR 500, and creatinine is 2. So what should we do next? Is it okay? Are we happy? No, the sugar is still not controlled. So think of adding another hypoglycemic agent with nephro and cardioprotection. And here you have GLP-1RA, which are used for patients who have not achieved glycemic targets despite use of metformin and SGLT2, or those who are not able to use these medications. So this is important. And you have, again, trial evidence, primary renal outcome trial, the FLOAT trial, which established the role of semaglutide for renal protection and also cardioprotection as a secondary outcome. So this can be added in our patient. And this is a class effect. You might ask whether semaglutide alone? No. The other GLP-1 also are equally effective. But again, the trial evidence, primary renal outcome trial as of now is with semaglutide. So our patient was put on semaglutide subcutaneous weekly, 0.5 initially and then 1. At 6 months, where is he? The creatinine is 2, UACR is 430, HbA1c is normal. So we have finally attained the glycemic target, but UACR still continues to be high. It's 430 milligram. What do we do next? How do we target this residual risk after giving SGLT2 and even GLP-1RA? What can we do? Is there anything available? Yes. So the 7th point on the prescription is another organ protective drug, that is non-steroidal MRA, which has proven kidney and cardiovascular benefits, and it's recommended for patients with type 2 diabetes if the GFR is equal to or more than 25, the serum potassium is normal, and there is persistent albuminuria despite other standard of care. Our patient, Mr. S, fits here because still the albuminuria is high. So this can be added, and we have sufficient trial evidence from Fidelio DKD, which was the renal trial, Figaro DKD, which was the cardiovascular trial, and Fidelity, which was a pooled analysis of both the trials. This established the role of finerenone in management of diabetic CKD. As of now, the role of finerenone in non-diabetic CKD is under evaluation. Find CKD trial, we're a part of that trial as well. And the top line results have been published, which shows that the finerenone can be used even in non-diabetic CKD as well, but it has yet to become a part of the guideline. So SGLT2 can be used in diabetic and non-diabetic. GLP-1RA as of now only in diabetics, and finerenone only in diabetics as of now, but soon that may change, and we will use this drug for non-diabetic CKD as well. Now, when we are using finerenone, some practical points we have to remember. UACR more than 30 milligram per gram, initiate. The patient should be a diabetic, serum potassium less than 5. If the GFR is between 25 to 60, initiate at 10 mg daily. If the GFR is more than 60, you can straight initiate with 20 mg. Now, if you have initiated with 10 mg, after 1 month, check the potassium. If it remains less than 5, even in the GFR of 25 to 60 group, you can up titrate to full dose, that is 20 mg. Both strengths are available in our country. Maintenance treatment, continue with 20 mg. Keep on continuing till the GFR falls below 15. You have to discontinue if the potassium goes beyond 5.5 or the GFR goes below 15. So these points are important, and try to keep the patient on the drug having started it, because this is also one of the pillars of therapy. So now our patient, Mr. S, this is the prescription. First is diet and exercise, telmisartan, amlodipine, chlorthalidone, metformin, dapagliflozin, semaglutide, and finerenone. Now, are we done? Is that enough? Let us see. So in this patient, what we've done, we've added these drugs sequentially, one after the other. So this was the traditional practice, and this is what we had done for this patient. But now we had confidence trial. So what was the confidence trial? It emphasized that upfront combination of finerenone and SGLT2 may be better. It's better than either agent alone in diabetic and CKD. So using empagliflozin alone, the USAR drop was 29%. Finerenone alone, the USAR drop was 32%. But if you combine them, the USAR drop, it declined to 52%. So that's an important renal outcome. So this was a short-term trial looking at the surrogate endpoints of proteinuria, and it showed a significant reduction in albuminuria with combination rather than each therapy alone. So the important message was it brought a shift in thinking about the traditional approach where we were using one drug after the other. So 6 months, now there is a paper by Tuttle, Catherine Tuttle and Newen in Circulation in 2024, which talks about a rapid sequence approach. So first week RASI, second week SGLT2, third week MRA, fourth week monitor, check creatinine potassium, and 5 to 6 weeks GLP-1 RA. So this is a rapid sequence approach, and it says that the 4 pillars of therapy should be added in a rapid sequence. They are the 4 pillars of guideline-directed medical therapy for type 2 diabetes and CKD, and these 4 pillars should be on your prescription because RASI has started the journey of kidney protection. SGLT2I changed the game. GLP-1 RA added benefit, and finerenone has closed the gap. So this is what you need to see, whether it's there on your prescription or not. Fine. Is that the end? No. What's the point number 8 on your prescription? Do not forget the statins. Remember, blanket statement, all diabetics with CKD, statin should be started even if the cholesterol lipid profile is normal for CV risk reduction. So if the patient is more than 18 years in a diabetic CKD, type 2 diabetes, statin should be a part of the prescription. Non-diabetic CKD, we start statins more than 50 with normal lipids for CV risk reduction. But diabetic CKD, remember one thing, all your adult patients of diabetic CKD, statin should be a part of prescription, not for lowering the levels. That would happen, but for CV risk reduction. So even if the lipid levels are normal, you are using statin not for dyslipidemia, for CV risk reduction. Add bicarbonate. So should we add bicarbonate to everyone? No. Target bicarbonate beyond 18. That's enough, because bicarbonate is expensive also, and then again may cause fluid overload because of the sodium. So we should avoid bicarbonate if the bicarbonate is already beyond 18. Also avoid bicarbonate if the patient has hypertension or fluid overload. So should not use in an overloaded hypertensive patient. Control those first and target bicarbonate above 18. That is enough. Don't keep on using if the bicarbonate is already normal. And the last but not the least important point on your prescription is some other important therapies apart from the management of creatinine. Aspirin should be used if there is established cardiovascular disease, not for primary prevention. So we did not add this in our patient because there was no history of cardiovascular disease in the past. So it's not used for primary prevention. Then what about febuxostat or allopurinol, uric acid therapies? So there's a lot of talk about uric acid. Remember, we give these therapies. Managing uric acid is important, but if the patient's uric acid is more than 9, you should give even if the patient is asymptomatic. If it's between 6 to 9, and if the patient is symptomatic, then you need to give these therapies. So isolated uric acid value of 7 without any symptoms at all, it may not be indicated. Now manage anemia, because that contributes to a lot of symptoms and progression of CKD. Target between 10 to 12, not beyond that. And you have so many therapies at your disposal. You have oral iron, very good varieties of oral iron, which are compatible, GI compatible. Then you have IV preparations, which have very few side effects, can be given as bolus doses. And you have erythropoietin. Remember, always first check the iron sufficiency. The TSAT, that transferrin saturation, should be 40% or above. These are the latest guidelines, and ferritin above 500. There is no point in giving erythropoietin to the patient, which is an expensive therapy, if the iron itself is low, because it's not going to work. The other important advance is we have now so-called oral erythropoietin. And what is this oral erythropoietin? You have medicines called HIF-PHI. In India, we have Decidustat available, which maintains the endogenous erythropoietin. So it's an oral therapy. So with erythropoietin, we had problems in cold chain maintenance in India and injection, but this is an oral therapy. Then also check for the mineral bone disease. So don't restrict yourself to the kidney and sugar. Check for mineral bone disease, which is very common. Normalize calcium. Check the phosphorus. Try to bring it down to normal, because many deaths occur because of cardiovascular disease, because of high phosphorus and vascular calcification. Maintain vitamin D above 30. And if the parathormone is high, PTH is high, use calcitriol. So one important message is it's different, cholecalciferol and calcitriol. Cholecalciferol is inactive vitamin D. So you correct vitamin D deficiency by cholecalciferol. But if the PTH is high, you give active vitamin D, which is calcitriol. So this is important. Don't use calcitriol all the time for vitamin D deficiency. What about vaccination? Do not forget that adult vaccination, especially in DKD, very important. Influenza, pneumococcal, hepatitis B, and even varicella and zoster now, depending on the indications. So Mr. S's final prescription is diet, lifestyle, stop smoking, the BP control, sugar control, organ protection by DAPA, semaglutide, finrenone, CV risk reduction by atorvastatin, and sodium bicarbonate, and the other therapies. So this patient did not have the other problems. So he was vaccinated. His anemia, MBD was optimized. So this is what is a final prescription for chronic kidney disease. So why I'm emphasizing all these 10 commandments? You may say we all know it, but this is our paper. I was also a co-author in this, and this was published in one of the leading journals in the world, Kidney International. And this is our Indian study. We are a part of huge cohort study, Indian CKD study. And what did this conclude? That in India, 11 tertiary care centers in early stages of CKD, where we have collected data for 3966 out of 4056 patients who had complete prescription data. RAS blocker use was only less than 50%, statins less than 50%, metformin only 26% of patients with diabetes. People are scared of metformin, and iron and erythropoietin dismal. So this is what we are doing, tertiary care centers, nephrology tertiary care centers. So I think something needs to be put right. So thus in 2026, remember, we cannot regenerate the nephrons yet, but yes, we can protect the ones which are left. And this we can do by two things, which I told already. Screen to diagnose early, that's point number one, which should be followed across continents, across races, across rural or urban areas, across all specialties. Screen to diagnose early and make sure your prescription has all the 10 commandments. So many people ask, fine, you have enumerated so many things. Can it be done in low middle income country? So this is again, we had written a paper, Equity and Quality of Global Chronic Kidney Disease Care. What are we waiting for? Because we know there are challenges in LMIC. The public is not aware. Majority population lives in rural areas. We have less number of healthcare professionals or nephrologists. The per capita income is low. GDP is low. Majority of DKD stays in LMIC. Poor access to dialysis and nephroprotective drugs are costly. So you may say, okay, ma'am, you have given a lecture on 10 commandments. How do we follow them? We have so many challenges. But whenever there are challenges, we have solutions. In India, we should focus more on protection and prevention rather than treatment of ESKD. And how do we do that? Increase awareness among the public. It can be done by multiple platforms. We are having multiple webinars, but we should include the public also. We should have webinars not only for doctors, for physicians, for multi-speciality, that's happening. But even public speaking, TV, press, combined effort by all of us. We should train the primary care physicians. They should be given modules, not the theory, but the 10 commandments. Screen and follow the 10 commandments. That should be the message. So early screening, use a urine dipstick if you don't have anything, and check creatinine and EGFR, even for primary care physicians and non-healthcare workers also. We have ASHA workers in India, go door to door. They should do this point of care screening in the patient's house if the patient doesn't come to the clinic. and follow the 10 commandments. So diet focus can be done in any area, doesn't require too much of money. So do that. All of us are putting on weight, sedentary lifestyle, lack of sleep, more stress. This ancient literature tells us, I think we should go back to that, focus on diet. Schools, children, it should start there. School canteens should have healthy food, not chips and the fast food. So that should change. That happens with policy change. BP control, sugar control. So these 4, 5 points, what I told, are cheap options, can be done anywhere. Now talking about the costly nephroprotective drugs, packages for nephroprotection should be made under the government. Government has given beautiful packages for dialysis and transplant. It's happening free in our country. We have a Pradhan Mantri program, completely free. But unfortunately, as of now, we don't have a package for nephroprotection. So we can have an aspirin there if CV risk, or metformin, or we can have SGLT2, RAS blockers can be done. India has a huge generic market. Indians are very good. So LMIC, generic formulations, which work equally well as the innovators. So in LMIC and India, I think we should focus on quality generics and probably to increase adherence, the polypill concept. So that the policymakers have to think about how to deliver what we are advising, and implementation and audit. And the pay should be linked to performance. So the prescriptions should be audited. Doctors should also, we should be held accountable whether all the 10 points were there and whether we did the screening. And in the process, we should also enter the data at whatever level we are, primary, secondary, or tertiary care, to contribute to national registries, because we need to identify the burden before we can plan out our solutions. So that is the LMIC model. I call it the 7P model, where it's not only the physician, it's the primary care physician, the physician in the city or a super specialist, the patient advocacy groups. We have enough of them. Pharma companies, they can produce generic drugs. They can help in dissemination of knowledge. The policy makers, for policy changes, as I said, packages for nephroprotection, and we involve the press and picture people. Why I say that? Because I strongly believe Mr. Amitabh Bachchan in India eradicated polio. 2 drops of life. That was the message, and the oral polio vaccine was adopted, and India eradicated polio. So it's a teamwork. Team stands for together, everyone achieves more. It's not sufficient knowing, doing, implementation, and audit is equally important. So I give kudos to Government of India, a huge country with multiple challenges, but we are running the most successful dialysis program in the world, free dialysis. You can see the numbers there. And India does 20,000 transplants per year. India is only third in number out of so many countries as far as the number of transplants are concerned. After USA and China, third number is India. Unfortunately, these number of transplants are not sufficient for our 1.4 billion population. So India is doing a great job. Kudos to the government for providing free, affordable renal replacement therapy. But we shouldn't stop there. Ladies and gentlemen, I would say a good doctor does dialysis, we are doing that. Better doctor does transplant, even we are doing that. But who's the best doctor? The doctor who prevents end-stage kidney disease, dialysis, or transplant, who prevents the progression of chronic kidney disease in a diabetic. I would even go as far to say the dialysis units and cardiac ICUs we are very proud of. But are they something to be proud of? No, I feel the dialysis units and cardiac ICUs are monuments to missed prevention. We have failed. That's why the government is having to invest in dialysis units and cardiac ICUs. The future of CKD care is not rescuing the failed organs. It is preventing their failure. So focus on prevention. So thank you very much. And I thank all for the opportunity and for patient hearing. And I'll be happy to take if there are any questions. Thank you very much.
So much, ma'am. It was a wonderful and insightful presentation over the kidney diseases. We have Dr. Chong with us. Dr. Chong. Dr. Chong is the chairman for CMAAO.
Thank you, Professor Sahay, for a wonderful update on this very, very important problem. Here in Singapore, we have about, for a city state of 6 million people, we have about 2,000 new dialysis patients a year. about 2/3 of those are actually from diabetes. So again, we have 11% population who are diabetic. If you strip away children, 1 in 3 at the age of 60 are diabetic. 1 in 5 at the age of 30 is diabetic. So we also have a huge problem in Singapore. And your lecture today resonates with us that we should prevent, because the cost of dialysis, and it's not just the economic cost. I mean, the cost of basically the morbidity, the mortality is just, it's really, like you say, it's a monument to a failed prevention strategy. So, having said that, yeah, a very good update on the prevention, especially the role of pharmacoagents, the four agents that you mentioned, which indeed have revolutionized prevention of CKD in many aspects. I now ask whether any questions from the floor. If there are no questions from the floor, can I just ask something very that is always piqued my interest? When I graduated from med school, there was no such thing called the EGFR. I know EGFR is a calculated number, and creatinine, by the time it's above normal, shows that probably 50% of the renal function is gone. So I understand why EGFR was kind of invented, to see whether we can help predict the rise of the creatinine before it crosses the threshold. What are your thoughts on that?
Yeah, so the concept of EGFR is very important for us. And as you said, when we were students, we used to hate EGFR. That time we used to have like the measured measured GFR, where we used to collect 24 hours and all that. And practically it's not feasible. I won't myself do it in the clinic and all that. It's not possible. So EGFR has made life easy. And now the problem was initially EGFR, big calculations were there, which again, nobody was doing it. It was not practical. Now you have wonderful calculators. So I think everybody should download that EGFR calculator. Now the thing is, now we are moving ahead and we are talking about GFR based on creatinine, GFR based on cystatin C, because there are certain fallacies with the GFR based on creatinine as well. So cystatin C works better in those conditions. And there are formulae in the same app where the GFR can be calculated with either cystatin C or creatinine or both of them combined. So if you have a confusion about patients where the GFR coming borderline as per the creatinine, you can also do a cystatin C creatinine combined GFR. And again, you can ask it from the lab, they will do it for you. But the cost of doing cystatin C is 10 times the more the cost of creatinine. So if you want it, and for research purposes, in certain conditions, in very obese individuals, or those people who are at extremes of weight and all, we sometimes use cystatin C. So the children, we use a different formula. So all this EGFR is for adults. In children, we have another EGFR formula called the Schwartz formula. The easy thing is, all of us have smartphones. We are all smart doctors, be it physicians, endocrinologists, whatever. So the GFR, we can do it on our, calculator on the smartphone itself and try to mention it on the prescription. Soon a day may come that the patient may come and ask. Patients are educated. They have a right to ask. They'll ask, this was the guideline, doc. Why did you not do it for me? So have it documented on your prescription. Now, the thing is, the other problem now we are facing is, now most of the Indian labs are reporting the EGFR along with the creatinine. People get worried. So there it's showing that most of the time it shows that the GFR should be above 90. But in Indian population, mostly the GFRs are between 70 to 90. So the thing is, yeah, Indians, maybe we need to have Indian specific GFRs, cutoffs and all that, which has not happened so far. We follow the Western guidelines. But still, we can educate the patients if the GFR is between 60 to 90. But if you don't have any albuminuria, then you're okay. So GFR more than 60, if you have albuminuria, then you are having CKD. If the GFR is less than 60, continuously for 3 months, it's definite CKD. So I think the CKD concept and the GFR concept is important. At least the people are realizing that everything may not be normal. So that's my take on it.
Thank you. I understand where you're coming from, because at least it raises awareness. We have a question from Dr. Rakesh. Dr. Rakesh?
Yeah. Yes, same. I was just actually following on the same EGFR. So when we see the values from different labs, we see the variation is there. The same creatinine will give different EGFR values. So that creates a bit confusion, as Madam has said clearly that we need to have. My suggestion was that do we incorporate various factors, whether diet, although age and sex are already there, but should we also take into account diet, the ethnic build, and then devise a EGFR formula? And which one, ma'am, you are using currently in the Indian population? Because there's always a confusion which formula to apply and get the correct EGFR.
So that's a good question. But now the CKD EpiGFR, EPIGFR is important because it's not affected by other things, just the age, creatinine, and the sex. So that's important. The previous GFRs, we used to have race incorporated in that equation, but now we use the EPI equation, the latest one, which does not incorporate race because it's controlled for that. But as you rightly said, see, in India, the problem is, again, each lab gives a separate value, different value of creatinine. So we should use good labs, the NABL accredited labs only, and we should try to get the creatinine done by method, we know that IDMS method. So otherwise also, most of the labs do a modified rate-dependent Jaffe creatinine method. That's also acceptable, but there is a conversion factor of around 0.9. So it's fine. I mean, see, what I would say is, see, even if there is slight error, it's important to calculate a GFR and stage the patient. If the patient is somewhere between, say, 60 to 90 GFR, it's still all right. It's stage, I mean, you know that less than 60, you go into stage 3. So tell the patient and tell yourself the concept of stage, GFR. So creatinine 0.1 up, 0.2 down doesn't make a difference. The patient may
No,
still
that
be in
so
the
we are
same
using the
stage.
heat formula. Heat formula we are using, na? CKD G1 or
Yes, yes, yes. That's a,
A1,
that,
A2 or like that. That
yeah,
we
yeah.
are staging.
Yes, to do
My,
the
yeah,
staging. See, why
yeah,
I'm trying to answer your question using that heat map only. See, it's more important to find out which stage rather than pinpointing the exact value of creatinine, because creatinine may vary 1.3, 1.5. The
Yeah.
stage may be
Yeah.
the same. So the prognosis depends on the stage, not the exact value of creatinine. So try to explain that to your patient as
yeah.
well. And that's another reason
Just,
that GFR is important.
just a small query that what would be the standard protocol to the frequency of EGFR estimation, or sorry, UACR estimation in stable diabetic patients?
So if the thing is, like, for a newly diagnosed diabetic, especially type 2 diabetic, you have to start screening, I mean, from the beginning, the day, because we have a lot of pool of pre-diabetic patients as well. So start screening. And if everything is normal, then you can do it once in a year, annually. But in case there are abnormalities, then you need to screen them once in 3 months. So that should be the correct frequency of screening. And our Indian guidelines also mention that once in 3 months is not a big ask. We can do it.
No, we are actually in an insurance-based setup. I'm in UAE. So here, the insurance usually does not allow every 3 months. They say once in a year. So I just want to know from you what would be the correct appropriate suggestion to them, that we want to do it every 6 months, 3 months, or 1 year.
So see, that's the answer. What I said was once a year. If the patient is absolutely normal and you get normal parameters, your UAE is allowing once a year, that's fine. But if the patient has already developed albuminuria and the GFR is abnormal, then you have to test it again in 3 months, because you have to document that it is CKD, right? It might be
Yeah.
transiently elevated. So the UAE government should allow annual screening if, as long as the parameters are normal. But whenever you have a high albumin or a high creatinine, you have to ask for a repeat in the next 3 months.
Okay,
Yes.
got it.
Well, Prof, in Singapore, we use a guideline of for all diabetic patients every 6 months to
Okay,
measure the
that's good.
microalbumin. Yeah.
That's
We
great.
measure the microalbumin regularly for twice a year for all our diabetic patients. And then, of course, if their CKD is a different ballgame altogether. You know, they get
Correct,
referred to a
correct.
renal physician, etc., etc.
So what you
But
said is, see, you are doing a better job, maybe screening twice in a year. In
yeah,
our guidelines, we have put routine screening once in a year, because again, twice a year becomes expensive. But as you have already mentioned, if it's a CKD, if we think it's abnormal, we have to again check it more
of
frequently.
course,
So that's
of
what we
course,
are following. Yes.
yes. This is the most enlightening conversation, and yet it's very, very important as we see the huge avalanche or tsunami of diabetic patients sweeping through our healthcare systems. Is just overwhelming. And
But I think Singapore does a good job. I think you have policies in place. And in India, the thing is, I'm proud of what we are doing in India. We have unique challenges in India. I'm in 1.4 billion population. That's
yeah,
1,400 million. So despite that, I mean, we have now free dialysis. If you go to our dialysis portals, they are all open on open this thing. So you can check that huge numbers of dialysis, excellent dialysis centers. But the problem is, I think that's only half battle won. The other half is to reduce the burden on the government and on the patient by
yeah.
preventing CKD. And there we are not doing a perfect job. So I would like to know from you, Dr. Chong, I mean, do you screen everyone? I mean, what's the policies are in place, but are you able to screen everyone? And are all of them on nephroprotective therapy, the four pillars?
Okay, so in Singapore, for example, what we do is every adult, once you hit 35 or 40, you're given actually free blood tests to screen. So the first thing is we screen for diabetes, hypertension, diabetes, all the classic, chronic diseases. So the first thing that is out there is that every person about 35 to 40 is eligible for a free blood test, to monitor on, and it's on a yearly basis, mind you. It's not just a one-off. So that's the start of the whole program. And then once you're identified to be diabetic, your GP on the system will start to follow you up, etc., etc. Then you go into another different path. But the beginning is screening, screening, and screening for the whole population. Because we are overwhelmed. We have an 11% diabetic rate. So we have no choice. We have to tackle the problem upstream. Building a public hospital in Singapore now costs somewhere upwards of a billion Sing dollars. I mean, that's about maybe 600 to 700 million US dollars just to build a new public sector hospital. So it's insane. The amount of money we have to spend at tertiary care is insane. So we have to go upstream. We have no choice.
So
So
here
that's
in
where we are.
this aspect, we are ahead of Singapore. You said 11%. The diabetics, we have 18 to 20% diabetics. So I think that's again a big, big burden for us. Yeah,
Yeah.
absolutely.
Just curious, I always remember the statistic that if a diabetic is on dialysis, he or she is likely to perish of a stroke or a heart attack.
Absolutely.
50% within 3 years. Is that statistic still relevant today?
Absolutely. So in fact, there is a statement or a saying among nephrologists that those people who reach dialysis or transplant are the lucky ones because they have survived the cardiovascular events. So it's quite common. I mean, that's why I was talking about the CKM syndrome. In fact, the CKML now, the cardio, kidney, metabolic, and the liver. So MASLD, the fatty liver, MASLD is very common in
Yes.
India. Cardiovascular disease, both heart failure as well as the ischemic heart disease, very common in India. That's why we should get out of that only glucocentric approach. We should be holistic. And that's why the organ protective drugs are important. So good thing what has happened in India is we have a huge generic market, and India is
Yes.
the, I think, leading supplier of generics to rest of the world as well. Generics are good quality generics. We are really
Yeah.
proud of our pharma industry, the way they innovate, because making a new drug is difficult because of the cost involved and all. But generics, they are absolutely wonderful. And
Yeah.
I mean, we have generic semaglutide now. We have generic
Excellent.
SGLT2 inhibitors now. So in fact, our use of SGLT2 and semaglutide is going to beat the use in USA. Because I used to think SGLT2 90% in USA. No, it's not like that. We are far ahead. Similarly, GLP-1 RAs, because they have become off patent and generics. So only thing in India, we have some pluses and minuses. The plus thing is that we have a good primary care, secondary care, tertiary care system. We have a huge population resource. So we should not treat our population as a burden, but as a resource. Involve the non-healthcare personnel to deliver the complete protocol. So they should be trained, use generic formulations, and make sure that the policy is implemented and audited. So I think that's what is required. We have packages for dialysis and transplant, free packages. Lifelong dialysis in our center is free. Transplants are free, liver transplant free, lifelong immunosuppression free. But where we are failing is the universal screening, as you said. I think that's the next step. That has to happen. And the 10 commandments, that's it. Education, awareness. And these are all low cost methods. So I think there is where we need to focus.
Thank you, Prof. Saha, for a wonderful discussion and lecture. So we've come to the end of our session. Thank you very much again. Much appreciated your discussion and the lecture again. We thank you very much, and we look forward to seeing you again soon for more of this topic. It's always a powerful and important topic to all of us. Thank you very much.
Thank you. Thank you for the opportunity. Thank you very much. Pleasure.
Thank you, Dr. Manisha. Thank you so much for the wonderful talk. We would like to wind up this session. It's already 10:34. So we are over an hour. Just one question we have on internet is that, these days, a lot of people are taking painkillers, just random, there's a lot of, it could be a headache, it could be crocin, it could be anything. What effect is it bringing on the kidney, and what effect is it like, how effective it is?
Yeah, so I think I'm happy about the question also, because the thing is now people are at least becoming aware that painkillers, especially the NSAIDs, they cause deterioration of renal function. So they are important causes of kidney failure and the progression of kidney failure in our country. So that's important. So pains and aches will be there. We should try to reduce them by other methods. We have other methods for meditation. Those things doesn't work. You can go for paracetamol. There are certain safe painkillers as well, but use them only when they are required. Otherwise, you are adding that component to the progression of CKD. In addition, they cause hyperkalemia and they restrict the use of other guideline-directed medical therapies. And in India, the other problem which people have not spoken about, and I also did not mention it, is use of alternative medicine. So that also is a big thing which we have to, tackle. So we have Ayush system in India. So I am a believer in the natural therapies and all that, but it should be prescribed only by an expert. It should not be, unlicensed indigenous medicine. So I would emphasize the word unlicensed indigenous medicines. Yeah.
Dr. Anjali, do you want to say something before we wind up the session? You have some comments there?
Yes, this was a very, very powerful presentation. I want to congratulate the Prof on this. I was now, whilst he was talking about the painkillers, it's a big problem because normally your chronic kidney disease is in your elderly patients, and they all have arthritis, and that, and unfortunately you feel the arthritis and you don't feel the chronic kidney disease. So which makes it extremely difficult, but we have also started to educate our patients, and we also go to paracetamol. There's not a lot that you can do, and they do understand, especially if they use the NSAIDs and they see how their GFR further drops. That's normally when the penny drops, but then you have to get it back up to a higher level again. I also think that sometimes we are so, in South Africa, we're very specialist and hospice centric driven. And a lot of, especially listening again to this talk this morning, should actually be that in our country, the general practitioner should be allowed to treat these patients. We are restricted. We need to send them all to nephrologists. We don't have actually nephrologists or enough nephrologists in our country to help with this burden. And yes, and just one thing that was coming into my mind, between spironolactone and furosemide, which one would be preferable in your chronic kidney disease patient? Thanks.
Okay, thank you. Thank you for those positive comments. So generally we use furosemide for any volume overload. So that's a drug of choice. And it's also a part of the triple therapy for hypertension. So as I said, the order would be in a hypertensive patient, you use a RAS blocker, calcium channel blocker, and a diuretic. So generally we use a thiazide diuretic, but if the GFR is less than 30, we go for furosemide. Now, spironolactone is specifically indicated in those patients who have either resistant hypertension. And we call resistant hypertension if the patient fails to respond to 3 drugs in full doses, one of them being a diuretic. So if the patient fails the first 3 medicines and hypertension is not controlled, we add spironolactone, provided there is no hyperkalemia. So that's important. The other important thing is spironolactone is a very good drug for management of heart failure with reduced ejection fraction, has strong trial evidence for that. So we use spironolactone for resistant hypertension or for heart failure with reduced ejection fraction. Now you are having other drugs as well for that indication, but for volume overload, first you use a thiazide diuretic, less than 30 GFR, you use a furosemide. In case resistant hypertension or HFrEF, we go for spironolactone. I hope that answers your question.
Thank you.
So if there are no more comments, we would like to wind up the session on a very good note. Thank you so much, Dr. Sahay, for a very insightful and a very, very important topic at this hour. It's a need of an hour. We would like to bring you in a follow-up session. Till that time, we would like to wind up the session and see you again next week. Thank you so much, everyone.
Thank you. Thank you.
Thank you. Bye.
Thank you.
Nice interacting with
Goodbye.
you. Bye-bye.
Bye.